Now, next speaker will be Gabriela PALIS, who has had extensive experience in education, first in the ICO and now in the Ophthalmology Foundation. She's from Buenos Aires, Argentina. And she will be talking to us on trends in curriculum development for resident training, entrustable professional activities. Gabby.
Thank you, but this is not my presentation here.
Oh. Can you change the presentation,
I'm not
please?
one.
No, the previous one. Dr. Anna Palis.
Thank you very much. I have no conflicts of interest. In fact, I don't know anyone in medical education who has conflicts of interest in medical education. So. The goal of my presentation will be to define entrustable professional activities, to describe the benefits they have in curriculum development, and to demonstrate an example. Entrustable professional activities were defined, or the concept was developed by Ole ten Cate, who is an educationalist working in the Netherlands, and he defined them as a unit of professional practice. This is what we clinicians do as daily work, such as, for example, performing a cataract surgery, or managing a patient with glaucoma, or designing a dry eye therapy protocol, that can be fully entrusted to a trainee once they can do it safely. EPAs have come to facilitate the translation of competency frameworks to practice. Competency frameworks in the last years have become very granular, and they are difficult to, each of the competencies are difficult to assess. In fact, the 2015 CanMEDS version has 700 components of competency, and this has been proved to be difficult to assess. So, entrustable professional activities have come to help with this problem. They describe work or tasks that residents can perform, and they are independent of persons, while competencies describe persons who have knowledge, skills, and attitudes, so they are more difficult to assess. EPAs integrate competencies, so for each activity, there are many competencies that can be assessed. For example, for performing a trabeculectomy, medical knowledge and patient care can be assessed, and for requesting a cornea donation, interpersonal and communication skills and professionalism can be assessed. Tied to entrustable professional activities are the entrustment decisions. And this is the decision to transfer a responsibility to a learner, to tell the learner that he is able to perform this activity independently. These decisions can be dichotomous. We entrust or not yet entrust the learner, or with decreasing levels of supervision. The first level, the learner will be allowed to be present and observe, but not to enact. The second level, he will be able to execute the activity with direct and proactive supervision, but with the supervisor present in the same room. The third level will be to execute without the supervisor, but the supervisor should be quickly available in the next room, for example. The fourth level will be to act unsupervised, and the fifth level will be he will be supervising other students or residents. There is little that has been published about entrustable professional activities in ophthalmology. This was the first paper actually by Hoff, Frenkel, and Imhoff. Imhoff is the ophthalmologist in this paper. And they have been using the EPAs in Ole ten Cate's hospital that is in the Netherlands, in, sorry, I can't remember the name of the, Utrecht. And in fact, for the Association for Medical Education in Europe guide for describing EPAs, they have used an example related to cataract surgery. So it's an EPA for managing patients with cataract. So each EPA needs to have a title. the title has to be a simple one, and it has to be describing an activity. So, for example, managing patients with cataract. Also, each EPA has specifications and limitations. We'll not see all of these because there are too many, but just to show a couple of examples. So the non-technical specifications, for example, are that the resident will need to know the medical history or the interpretation of specific investigations. The technical aspects of it will be the administration of local anesthesia or the performing vacuum emulsification and intraocular lens implantation. And the limitations of this EPA are that it does not apply for patients with high risk because of patient-related comorbidity conditions. The potential risk in case of failure, this also has to be part of the activity. So if the resident does not learn the activity properly, for example, intraoperative complications may occur or undue financial costs and societal impact. Also, each EPA has the competency domains that are included in the activity, such as for this one would be medical expert, communicator, collaborator, or professional. Each activity should include the required knowledge, skills, attitudes, and experience that the resident needs to have or to live through to acquire this, the domain of this activity. So, for example, regarding knowledge in cataract surgery or in patients with cataract, he will need to know all the aspects of disorders of the lens. The technical skills required will be, for example, handling of the microscope and phaco machine. And the non-technical skills, an example of this would be adequate communication with the patient pre, per, and post-operatively. The experiences required will be the completion of the simulation training program, the wet lab training program, or at least 250 supervised cataract surgeries. Also, each activity needs to provide the information sources to assess the progress and support the summative assessment, such as video recording of 80% of procedures or 100 supervised satisfactory full OSATs in the operation suite. Each activity also needs to include when is which entrustment or supervision level expected. So, for example, in this case, in the Netherlands, the resident is expected to reach the unsupervised practice in his 4th year. And also, each activity has an expiry date. If the resident does not practice the activity for X time, in this case, if they don't practice cataract surgery for 2 months, they will be coming down to indirect supervision. The Royal College of Physicians and Surgeons of Canada have defined also the EPAs for ophthalmology. They have grouped them in 4 groups. Again, we will not see all of them, but just to show a couple of examples. The first group is transition to discipline. So, for example, this is for first-year residents. They need to learn to perform basic ophthalmology examinations or gather a history for patients with common ophthalmic presentations. The second group are the foundation EPAs, such as assessing and providing initial management for patients with uncomplicated medical and surgical presentations or performing basic ophthalmic procedures. So there are 9 foundation EPAs for residents. The third group is the core EPAs. So here we have, for example, performing or interpreting diagnostic investigations or performing retinal procedures or oculoplastic procedures. There are 15 in total that are core EPAs. And the transition to practice, which are to be learned by residents in their last years, such as teaching other learners or running an outpatient clinic. When building a curriculum with EPAs, the recommendations are to identify first the EPAs that are relevant for your own setting, to create a full description of the EPAs, or to take some that have been described already, but to adapt them to your own setting, to determine how they are going to be assessed, and to establish the way that the residents are going to learn them. So in conclusion, EPAs represent what we do in our jobs. They allow to translate the competency frameworks to clinical practice, and they provide transparency to training and assessment through trust. That is what we usually do when we say that our residents are able or not able to do an activity. Thank you.
So I have a question. So it seems like a lot of work to create these. What do you think the benefit is
The benefit?
of having EPAs?
The benefit is that they are more easy to assess, I think. Because they describe activities, you will not probably have to go through all of the granular aspects of competencies defined in competency frameworks. So that's the benefit.
Any other questions? Or go to the mic, yeah.
Yeah, I have a doubt. EPS, if we introduce, what about like if it's a fixed curriculum, fixed course, like 3 years or 5 years, and if a resident does not achieve that particular level of EPA, so do we still allow them to move ahead? Or because this goes with a variable course, it's fine. But what if it's a fixed course and we bring in EPS?
Well, the other benefit of the EPAs are that you do not need to have a fixed program where the resident has to achieve a specific EPA in a specific amount of time. So you can give them more time to learn that activity. I don't know if that's a question.
So the program has to change then. Like if we can't have a fixed program, like post-graduation we have for 3 years or 5 years.
If you have a fixed program, I don't know.
Well, I think the question is, what do you do if they're not meeting their,
Right.
they're not progressing as you want them to? And I mean, I guess all you can say is, if they don't, then yeah, if they don't, yeah, remediation. I mean, I think the most important point to your question is identifying it really early, so that you can give them the feedback and whatever the advice is to get them to get where they want to be. If it's all of a sudden you realize, oh, it's year 3 and they haven't met the criteria, well, hopefully you've been telling them that all the way through, not just at year 3, because our goal, of course, is for every student, every resident to become a competent ophthalmologist. So I think early identification, which means you have to have early assessment methods and to let them know, okay, you're not moving along like you should be, here's what we need to do. So it requires a lot from the teachers, the faculty, to give the good and constructive feedback and to work with them. And if they can't, and ultimately if they can't do it, then you can't let them graduate. I mean, would be my opinion.
The second thing is same with APS. How do we had done some work in my previous institute, that's why I'm asking. You said recordings, because once we have EPS in the curriculum, there has to be evidence to support that. So for all the EPAs, creating evidence ideally needs an e-portfolio, something like that, which all the institutes may not have. So I think it needs a lot of groundwork before we bring in EPS.
You need multiple assessment methods to make sure they're progressing as you want them to progress.